So I'm going to introduce our next speaker, Kenneth Feng. Kenneth is the staff psychiatrist and clinical director of the Asian Initiative in Mental Health Program at the Toronto Western Hospital, University Health Network. Kenneth is also an associate professor with Equity, Gender, and Population Division at the Department of Psychiatry, University of Toronto. His primary research, teaching, and clinical interests include both cultural psychiatry and psychotherapy. Kenneth, please come up.
So I'm just going to share with you some of my thoughts about trauma over the next 15 minutes or so, hoping that event that just happened wasn't too traumatizing for everyone involved. What I would like to do is kind of outline for you three things. One is kind of how do we look at trauma? What are some of the effects of trauma, psychological effects and mental health effects of trauma? And what are some of the treatments? And a lot of this would be from my bias and my perspective. And as you heard from the introduction, my interest and bias is along cultural psychiatry and psychotherapy. Unfortunately, not sponsored by any high-powered money company. Now, to begin with then, how do we understand trauma? So I just wanted to get a sense of prevalence of trauma in the room. How many of you have ever experienced a traumatizing event in your life? Would you put up your hand? Okay, so that's actually a small majority, I would say. How many of you have never, ever experienced anything remotely traumatic in your life? 2 people. Wow, I need to talk to you. What's the secret of avoiding all the traumas of life? So then it looks like that we have quite a familiarity with the concept of trauma, because I'm sure I can dig up the definitions, scientific definitions of what trauma is, but I was too lazy to do that. But instead, I think we can actually all have an intuitive sense of what it is. I mean, some of the common dictionary definition is experiencing something that is severely distressing. And if we look at the latest DSM-5, I don't know if DSM-5 is a welcome word here, but it certainly is controversial. In the PTSD literature, it describes it as experiencing something that is threatened or actual death or serious injury or sexual violence. So trauma is something that's severely distressing. And it can be directly experienced, and sometimes it can be indirectly experienced, such as being exposed to something that you see someone else experiencing something that's severely distressing, and then you also get distress as well. So watching the previous presenter sweat was giving me the nerves. So that would be an example of if you feel anxiety with someone else. But of course, we are also exposed to other kinds of trauma every day, even in the news, in the media, in today's day and age. And it can be kind of a single exposure or multiple exposure over time. Now, the thing about trauma, from my perspective, is it's actually very, very subjective. So it isn't to say that even though DSM tries to categorize those things, you're almost dying, you have a serious injury or sexual violence, those 3 concrete things. And of course, they try to concretize it. But certainly in my clinical experience, everyone has experienced trauma in a different way. And I'm sure that when I ask you to put up your hand, each of you have a very different experience in mind, what you experience as traumatic. So there's a very personal experience with what trauma is like and what is traumatizing to you. Conceptually, from kind of an understanding it from a cognitive perspective, it is trying to understand not only the event that occurs, but the situation in which it occurs, that is the context, the story, and the meaning. And I think that's what is the outcome of studies as well. So in other words, what's traumatizing for one individual may not be traumatizing for another individual because the context, the meaning of it is different for that individual. And how we interpret that, we can look at it several ways. But one simple way that I like to conceptualize it is the teeter-totter concept that when you are presenting with something distressing and overwhelming, you are always kind of measuring this against your capacity to cope. That is, you may be experiencing something extremely difficult, but at the same time, if you feel like you are in a position and power and you have the resources to cope, then maybe that event, although very distressing, may not be as traumatizing as it would be for someone else. Conversely, if you were placed in a position where you feel disempowered, where you're not able to cope either because of your internal resources is lacking or because you're put in an external environment where you feel that you have no control, then that event would be all the more traumatizing and damaging. So I think this subjective dimension is very important. I certainly see my patients, some of which have experienced very traumatizing life history, and yet they are quite resilient and they are coping very well. Conversely, someone else who by comparison from an external observer may seem like as a relatively minor trauma, but for that person is absolutely overwhelming. So I think that understanding the context and the meaning, it's very important to understand what trauma really is. Now, secondly, how do we understand the effects of trauma on an individual? So if we look at the emotional reaction of an overwhelming event, what's the common emotion that we all feel if you're being overwhelmed? What do you think? Shout it out. Yeah, fear. So fear and anxiety is probably one of the most innate emotional response, anxiety and fear. And so with the fear, we activate so-called the fight and flight response. So for someone who experienced a high trauma, they might feel like they want to fight, they're aroused. These lead to the so-called hyperarousal symptoms in certain people who have traumatized mental health disorder, or as well the flight response, which is to avoid, because that's the smart thing to do. When you're encountering something that seems overwhelming, you want to run away as much as you can. And so this running away can be physically running away, avoiding the situation, but also can be internally running away. And so in people with severe trauma, of course, we see the phenomenon of dissociation. And one way of understanding that, of course, it's an almost psychological protective mechanism to avoid what is seemingly overwhelming to the individual. And in terms of our response then, it's not only immediate, sometimes the effects of trauma comes out afterwards when there's a trigger, when there's a response. So I've experienced with patients who have experienced trauma in the past. I treat a lot of minorities and ethnic patients, a lot of patients from Vietnam or Cambodia. They have experienced horrendous trauma during the war, and they seem to be coping well until they experience something else. It could be a car accident. It could be staying in the ICU. I have one patient who stayed in the ICU. And just the experience of ICU, and as we talked about, being in a position where there was a loss of sense of control suddenly reactivated all the trauma the person experienced before during the war. Even though all the previous years in Canada, the person was coping well. So that would be an example of kind of delayed but triggered traumatic effects. Now, what does trauma in terms of the DSM look like? Again, this is a very restricted description, but the mental health effects are actually a sequelae then of what I described. There's the anxiety dimension. People will have a lot of anxiety symptoms. People will have the re-experiencing symptoms, that is, having them re-experiencing the event like flashbacks or in the dreams like nightmares. The avoidance is either psychological, avoiding the topic, avoiding the thought, or as well as physical, avoiding to do activities or going to certain places. And then there's the other dimension. Once you get into anxiety for so long, you might become depressed. So there can be negative mood and cognitions. And that's actually one of the new, in the DSM-5 as opposed to 4, new clusters of symptoms specifically about negative moods and cognitions. And then there's the hyperarousal, which means you're always alert and hyper, kind of the fight and flight response, the fight aspect, and then the possible dissociation. So these are some of the classic symptoms. Now, several things. One is that, of course, this PTSD diagnosis is fairly restrictive, and there are a lot of controversy about this. A lot of people have written that we should not, first of all, conceptualize as a mental disorder, but more like a reaction, a common human reaction to a threat, and calling it a mental disorder may be doing a disservice. There's also what I just talked about, how it's highly subjective. Each experience is different, and each person's emotional reaction is also different. So we have to keep in mind these controversies surrounding it. There are certainly people who write that we should really scrap the whole PTSD concept. But I think what is useful, though, at the very minimum, is that I highlight certain aspects of mental health distress that a person can get into when they have trouble dealing with the trauma, which is reactivated either in the present or as in a delayed reaction. So the third part, I want to just touch on how do we help people with trauma. And I look at it several ways. I think one of the first basic rules is, 1 minute, do not do any harm. And I certainly can't do any harm in 1 minute. So, but I think that this is something important to keep in mind because as this is a normal, we all have regular, normal physiological and psychological defense mechanisms. And I think that sometimes in the rush to provide aid, sometimes that's the very thing that actually makes the problem worse. So I think that's the very, very first thing I've learned, especially if we can harness both the person's individual resilience, but also the community. Because there are built-in mechanisms for both individual and community to cope and heal with trauma. So I think that's the first thing. The second thing are the common ingredients that helps in all kinds of psychotherapies and therapeutic relationships, and including, in a broader term, any kind of healing relationships beyond psychotherapy, including traditional medicine. And that includes cultivating hope, finding a sense of meaning, and I think you'll find a lot of literature about recovering trauma. It's about making sense, making meaning out of this. And thirdly, to increase one's capacity to cope. And just in the last extra minute or less, I would just kind of describe to you, there are different psychological paradigms to treatment. There's a very conventional model, is the cognitive behavioral therapy model, which says that we can help people by boosting their cognitive capacity to cope with things, including trauma. So in this case, what we talked about is looking at ways where we can increase our capacity to cope, or to see that the danger is not really as dangerous as it is, or that it's no longer here. So some of the cognitive interventions, but certainly behaviorally, exposure is one of the very powerful interventions. So one of the common procedures, even in CBT, is to allow the person to really talk about the trauma, but not in a kind of a half re-experience and then avoided way, to be able to reprocess the information. But secondly, I just also want to briefly mention is some of the newer wave therapies that are on the scene, including acceptance and commitment therapy, so-called the third wave psychotherapy. It brings into it a more Eastern philosophy about how do we cope with adversity. And rather than only seeing that we have to correct things by changing people's minds, kind of a convincing, acceptance and commitment therapy brings with it kind of a mindfulness component and acceptance component. And as you can hear then, coping with trauma is something that has happened in the past where the current situation may no longer be in the exact same way. Some of the factors may still be there, and certainly for oppressed groups, some of the external oppression may still be there, some of the external stressors. And so what happens is that the current situation is compounded with the historical problems. And with acceptance and commitment therapy and with mindfulness, what it helps the person is to be able to have a mindful grounding to the present, which is kind of a common technique used in the treatment of trauma, but also being able to accept some of the past that cannot be changed while building capacity to accept the inevitable, which is there's an end to every good talk. Thank you.
Thank you, Kenneth. This is one of those very few occasions where I feel I have power. Wow. So I'm going to next introduce Peter Menzies, who works with Aboriginal peoples. Peter is a member of the Sagamok and Anishinaabe First Nation. Peter is employed at the Center of Addiction and Mental Health and is responsible for creating the organization's Aboriginal Service Program, providing support to First Nation communities across Ontario. He has published numerous articles related to Aboriginal health issues and sits on a number of committees, both at the provincial and national level. Peter?
Ani, that means hi. So I was asked to do this presentation, and I will admit freely here that my knowledge of HIV and AIDS is not as wide as it should be, but my knowledge about trauma and the intervention is fairly high, but I see a lot of connections. When I go to communities, we deal with issues like suicide, opiates, and other issues like sexual abuse and physical abuse and all these other types of issues that are impacting First Nations communities. So thank you for allowing me to be here. And I know I only have 15 minutes, so I'll try to go over 500 years fairly quickly. So I'm going to see if this thing works. Yes, it does. So basically, I'm going to try to help us understand what the intergenerational trauma is, what is the impact, and conceptualization in terms of practice, in terms of research and direct. So without going into details, like we know the Indian Act governs Aboriginal people to this day. So for the last since Confederation, 1 year after Confederation, the Indian Act has pretty well defined what Aboriginal people can do. For example, the Indian Act defines if you're an Aboriginal or if you're not an Aboriginal. So if you have a status card, then you will be considered Aboriginal. However, if you have a status card and if you're not a band member, then you are considered that you don't have a band membership, which means you don't belong to a First Nation community, even though you think you belong to a First Nation community. So it becomes very bizarre when you start looking at people's development. And I'm saying this because this impacts our youth, and it impacts people that are struggling with their own identity as to who they are. And it's really bizarre that you would have a state defining if you're Aboriginal or if you're not Aboriginal. So we know the purpose of residential school is very traumatizing for many of these children. Many of these children left at 3 years old. They were forcibly removed from their parents or from their extended families. Many of them had their haircuts, changed their names, and things like that. Many experienced sexual abuse and physical abuse. And so all these children experienced so much traumatization. Many of them did not go home until 10 years after. And it's generations after generations that continued to go to these schools. And so it's really interesting when you think that they believe that over 1.5 million Aboriginal children went to these schools across Canada. That's a phenomenal number. It really makes you think about what kind of child rearing practices these kids were going through and how their language and their spirituality and always being challenged and being told that you're no good and you're going to amount to nothing and things like that has really traumatized all these children. We know that the research shows that that families have been destroyed, extended families, communities. Like we know that many residents of these institutions forgot what the word love means, feeling for others. I deal with clients who would tell me that they don't know how to deal with a female because for 10 years they were in a male residential school. And so they lost that, connection of, how to deal with the opposite sex. And many of us learn that through our brothers and sisters or through the school systems that we go through. So community values and things were destroyed. We know that when you look at the research today, many of the survivors are still impacted by the negative experiences that they have. We know through research too that even the second and third generation that have not been to these schools are also affected by transmission of intergenerational trauma. So we can see from the closing of the residential schools, the child welfare system came into play. And that's another form of colonialization. So many of the families were in these First Nations communities, and we really have to think about 7 to 8 or 9 or 12 generations going into these schools, being put back into the communities, and they were unable to leave their communities because the Indian agent did not allow them to leave. And so many of these communities did not have like social workers or psychologists or psychiatrists to help them deal with these types of issues. So it just kept on festering and festering because people who are hurt tend to turn inside or they tend to turn outside. Many of them just close down. So when children come along, they may not know how to care for them. They may not know how to love them. And all the traditional parenting skills that they would have learned if they would have stayed at home have been denied them. So many became parents without knowing how to be a parent. Many of us who have children probably learned how to be a parent through our own parents by observing and watching them. And that's how we raise our kids. So they look at Children's Aid as another form of residential schools. It's just taking thousands of children away. So we know there's over 27,000 Aboriginal children in care of a population of 53,000 Aboriginal, 53,000 in total that are in care. So that's a fairly high number of Aboriginal children that are in care. So when we look at the data, we begin to see there's high rates of suicide, there's high rates of HIV, there's high rates of concurrent disorder, which is fairly high within communities compared to the mainstream population. And so when we look at the data out there, it suggests to us this is the current stuff that there's a lot of child abuse going on, domestic violence, cultural loss, language loss, and there's all these types of things that are going on. These are individuals, when you work in these communities, you begin to realize that they are isolated. So when you go to remote communities, you have to fly into these communities, and services may not necessarily be there as we may have here. And I always like telling the story that if you go into certain communities, and if there's a hospital there, don't assume that it's a hospital. We can go down university and assume that a hospital is a hospital because it's going to have all the necessary services that we need. But when you go into northern communities, a hospital may not have the services that we expect them to have. And so when it's raining or snowing or windy, then orange, which is the emergency service, may not come out. So people call this intergenerational trauma. It basically means that through the Indian Act and 500 years of colonialization, people have been impacted negatively by all these laws. So it was mandatory to go into residential school, and when a child welfare worker back in the 50s and 60s felt that the family was unhealthy, then it was by law that you went into care. So again, people talk about spiritual abuse, emotional abuse, physical abuse, and mental abuse. People are really struggling with their identities. I mean, do I believe in Aboriginal issues, or was I raised as a Christian? And so what does that do to my identity? So there's a real struggle going on. So adults of former residential schools are struggling, and their children are struggling, and many of these people that attended these institutions have lack of identity. Many of them are struggling with substance abuse. Many of them go into risky behaviors that we won't go into, right? Because they just feel the world is hopeless and there's no place for them to go. So working with these traumatized individuals is extremely difficult. It really begs the question whether, and I'm not challenging Dr. Fong, but it really begs the question, are we dealing with PTSD, or are we in fact dealing with intergenerational trauma, which is not a diagnosis within the DSM-5. Many oppressed communities are trying to find a way of defining what has happened to them. For example, the community in the southern states, the Black community, they have a thing called the post-traumatic slavery disorder model. And that's trying to help them to define what their reality is and how they see the world. So this is kind of a model that was developed by us, and it talks about some of the symptoms that people may have when they're experiencing these types of traumas, from an individual to the family to community. So trauma is transmitted either through the verbal or through behavior or various other means through your extended family, and the child takes this all in and begins to start exhibiting types of behaviors. So again, it's really what is the focus of working with First Nations people? Is it from an individual perspective? Is it from a family perspective? Is it from the extended family, or is it from a community perspective? Most of us tend to think that if we focus on the individual, it's kind of blaming the victim approach, because we look at issues like the Indian Act, the social determinants of health, and what Ottawa's position is with First Nations communities. So it's merely not just trying to get the person to open their eyes and to get better. It basically means that when you look at these types of models here, intergenerational trauma really impacts just not the individual, but it impacts the political system, it impacts the economic system, and it impacts the social system. So you really have to, when you start working with individuals, you really have to have that as your foundation. You cannot go in there with an individualistic, perspective. You cannot go in there with saying this person has bipolar and leave it like that. There's many elements that are affecting these individuals that may not necessarily be affecting us. So I have 1 minute left, and I'm amazed that I dealt with 500 years in 15 minutes. So anyways, so when you start doing your research, or if you start working with First Nations people, I tend to look at, resiliencies. How did you get here? Then I look at their strengths. What are the strengths that you have, right? So you really got to start focusing on the positive to help them move forward. And then you got to look at the community and the tribal system, because First Nations and tribal systems have their own meaning of what life is and what mental health is. So in mainstream society, we say mental health, and within Aboriginal community, we say Aboriginal wellness. So it's a different way of thinking about things. So when I think about mental wellness, I think of 4 quadrants: the spiritual, the emotional, the physical, right? And so I start thinking around that way of thinking. So when I'm working with an individual, I have 4 things to work with that individual. Then I start looking at their family, extended family, and community. And only then, when we start approaching it in that way, same as research, then we'll be on a better road. So if you are doing research in HIV or AIDS, it's best to really get the foundation. What is the foundation of this community? Yes, we know the general reaction of the Canadian society, but what is the lived life experience of this community? Once you can answer that with the elders and the community participants, then you have a better foot in terms of the foundation of what you're trying to achieve. I believe that when you get to the foundation of a person or a community or an individual, you draw out a new meaning to that person. And that's the key. Miigwech, and I think I'm getting hauled off.
Thank you. Yeah, you keep it. Thank you very much, Peter. So I'm going to invite our next speaker to come up. Our next speaker is Tim Guimond. He is a clinical scientist at St. Michael's Hospital's mental health program and a PhD student at the Dalalana School of Public Health in the Biostatistics Division. Tim's interests are in community-based intervention to reduce primary and secondary HIV infections, and particular interest in motivational interview-based approaches.
Hello. So I'm here today to address how we address trauma with individuals who are using substances. Sorry, I'm a little too short to see over this, so I'm going to move to the side. And I wanted to start off by really quoting just from Judith Herman. A lot of my own reading and other people kind of start with trauma with reading Judith Herman. And she speaks about the silencing of trauma historically and over time. And she starts the beginning of her book with, the study of psychological trauma has a curious history, one of episodic amnesia. Periods of active investigation have alternated with periods of oblivion. Repeatedly in the past century, similar lines of inquiry have been taken up and abruptly abandoned, only to be rediscovered much later. Classic documents of 50 or 100 years ago often read like contemporary works. Though the field has in fact an abundant and rich tradition, it has been periodically forgotten and must be periodically reclaimed. And with those words, I just wanted to thank the OHTN for bringing this to a discussion here, to think about how does trauma inform. And in the idea of speaking truths, I will make my disclosure. And my disclosure is that I'm funded by the OHTN to do my research in biostatistics. So I wanted to kind of just say some of the things others have already said, but to kind of clarify what I will be able to focus on and what I cannot focus on in terms of what we understand already about treating trauma and substance use. Trauma is, of course, larger than PTSD, but our research tends to focus on post-traumatic stress disorder. And certainly not everyone who has been exposed to trauma develops PTSD, and we're still trying to understand how that might be. We also know, though, in HIV research, that HIV-positive women have been exposed to trauma at much higher rates than the general population, and they have higher rates of PTSD. Both trauma and PTSD seem to be risk factors for HIV transmission, for HIV incidents. And so here, I'm going to focus on PTSD, but where possible, mention how other traumas can inform our ideas. And it's with this spirit that I hope that we can talk about some of the solutions to helping people move on from trauma. This is a slide I put together from, excerpted from a review, a meta-analysis done by a team with Mettinger, Wilson, Haber, and Weiss, which was very impressive in that they brought together several studies to just look at the rates of trauma exposure and PTSD amongst women living with HIV. And it is, just to look at the first two lines, recent PTSD, 30%. A reference population for women in the US in general, 5.2%, almost 6 times. Intimate partner violence, 55.3% of women HIV positive amongst over 8 studies and 2,200 women represented there. And the reference population for the whole US, 24.8%. It's just astounding when you think about these rates just in general, how women are being exposed to these rates of trauma, even amongst the general population, and then to think that women with HIV have such high rates. Sorry, wrong direction. The evidence is sparser if we start looking with gay men, we start looking at African-American MSM communities. If their studies are smaller, it's harder to get a picture because the idea of doing cross-population studies to get these prevalences identified are harder. But you can see still high rates. Childhood sexual abuse by David Brennan, who's here at our conference, and his team, saw 19.4% amongst HIV-positive men and HIV-negative men, 16%. For African-American MSM, those rates of 45% for childhood sexual abuse, 8% for adult sexual assault, 6% for adult physical assault are just astounding. So when we think about treatment, we hope to give people the inspiration that no feeling is final, that trauma, we can move beyond, that we can feel healthy again. And this trauma treatments tend to be in 3 phases: an establishment of safety phase, a remembrance and mourning, and reconnection with ordinary life. And most of the treatments I'm going to describe now have focused on just phase 1 of treatment, that the establishment of safety has been more difficult for people with substance use because it turns out that when people stop using substances who have comorbid post-traumatic stress disorder, their anxiety symptoms, their other symptoms increase. They feel worse when they stop using drugs and alcohol. This is understood through a self-medication kind of hypothesis. The alternative is also true, that people go to treatments for PTSD without addressing substance use. They tend to also turn to substances more frequently for relief. So treating with these things in an integrated fashion has been felt to be critical. Again, substance use and dependence are 2 separate entities, and the research we have tends to be on dependence. But we also know substance use is a risk factor for HIV, as is substance dependence. This is in to remind us that harm reduction options for individuals who may not have access yet or who are on waiting lists to get into these treatments, they're hard to find, is an important thing to keep people alive and well and safe in the meantime. So practice guidelines for PTSD have been published at different intervals. This is a large tome from the International Society for Traumatic Stress Studies. They've published their second edition in 2009, and most of the research there is collected up to about 2007. They have one single chapter on comorbidity, and a subsection of that is on substance use. Their approaches, in general, we think of either being integrated, where we try to treat both disorders simultaneously with one provider, or parallel, we have to find an expert in substance use and an expert in trauma who will work beside each other, essentially, hopefully in communication, or sequential, which has been the most common recommendation given to people. Please go get your substance use under control, and when that's done, come to see me to treat your trauma. We don't really believe that that sequential treatment is the most sensible, and so most of the evidence from this point forward is going to be looking at models that are either integrated or are in some way trying to trying to capture two different modes of working at the same time. Seeking safety, the first one here, has what we refer to as level A evidence. This has 7 pilots, 2 randomized control trials. At the time that this publication came out, this modification of CBT, which was 25 sessions, had been used individually and in groups, used with men and women, and was really just a phase 1 treatment. It was shown to be helpful in reduction of both substance use and in PTSD symptoms in both of those trials. All the other trials that were looked at, none of them were randomized. There's a collaborative care, it was a non-randomized, at least a comparison of 120 people. It was a combination of different models, but it was based in a prevention. It was an idea these people had traumatic experiences, but did not necessarily have had development of PTSD, and this was trying to prevent the development of PTSD. Concurrent PTSD and cocaine dependence was an integrated program using PE, which is referred to as prolonged exposure, a very classic approach to treating PTSD, with coping skills and relapse prevention treatments that are common for substance use. It showed great promise, which is why it has B-level evidence, but no RCT to back it up. And then there were other ones that were being trialed in non-controlled pilots. In fact, acceptance and commitment therapy was put in the manual because there was one case study, and not to slight acceptance commitment therapy, but when you're writing practice guidelines and need to begin resorting to describing the case studies, it means you have very little in the box to describe for treatments. And in 2000, so seeking safety sort of came out from those guidelines as the recommendation. However, in 2012, a publication came out that had done a literature search up to 2011. They found 2 additional RCTs and 1 additional pilot study of seeking safety, which now kind of called into question its efficacy, because in these trials, they found no differences on substance use and trauma symptoms in these 2 settings. One with incarcerated women who obviously attended every one of their sessions of the treatment as usual. And so looking at not participating was a hard thing to do there. But the larger trial of 353 women's health education versus seeking safety found no differences on PTSD or substance use. There's a new CBT for PTSD as a pilot study, and imaginal exposure, an RCT, which showed good study but didn't follow people after the end of their treatments. This brings us up to kind of present day. It would be nice if we knew what our future held for us to make our decisions. And I needed to put something about Star Trek because I love it. So here we are with current research. In 2012, in JAMA was published a study looking at combining the prolonged exposure type of treatment with a standard substance use treatment and relapse prevention, counseling, detox. It was a treatment as usual community setting, and people could make use of various things. They added an additional 19.5 hours of prolonged exposure. Interestingly, there were 55 people in the PE, the prolonged exposure arm, and 48 in the treatment as usual. They found no substance use differences between the 2, but found better outcomes on PTSD symptoms by the final outcome, which is in that very busy slide. They did this 2 ways, looking at continuous outcomes and at other continuous and non-continuous outcomes, like the number of days drinking, found very similar outcomes. Interestingly, the dropout rates are slightly higher amongst the PE. It doesn't until the end reach significance for statistical significance, but it turns out that people were dropping out of prolonged exposure more rapidly. Whether that's because they're getting better quickly or because the exposure to these memories had them withdraw sooner isn't really known from this, and I think an interesting question to consider. In another trial, this one's interesting in that it combined a medication, naltrexone, for substance use disorder, and comorbid alcohol. The PTSD they treated with prolonged exposure. Again, they had 4 randomization groups. They found they had significant loss to follow-up, around 50% in some of their groups, and they found no differences during the treatment period, but post-treatment they began to see that the people in the prolonged exposure groups maintained their benefits, while people who did not to receive the prolonged exposure lost their benefits. They also found a consistent finding that naltrexone improved people's outcomes. Thank you. And this was just sort of a restatement of that in the table. And again, this is a study in JAMA. And then one last study I'd like to tell you about, which unfortunately does not deal explicitly with substance use, has to do with trauma and HIV. And in this RCT, 40 people living with HIV were given prolonged exposure, and 25 people in the control group who did not. And in this, they found decreases in symptoms in the HIV-related and non-HIV-related trauma symptoms. And so HIV-related trauma symptoms would be discrimination and bashing, different sort of behaviors that people might be exposed to and trauma related to because of their HIV status. I have some concerns as a statistician about exactly how they carried out their analysis, but I think it's a very interesting study to look at, and a larger study would be welcomed. Another concept, just to kind of put on people's map, is the idea of trauma-informed care. We may not be trained up in ASOs to be able to provide trauma therapies, but becoming informed in how to care for all clients who face trauma is an important thing that we've had to learn to do in substance use care. And I believe that these sorts of ideas could well serve ASOs in understanding how to address and meet the needs of people with trauma histories in a more successful way. These are some musings, which I'm sure during our panel they may come up or may not. So, oh well, I'm out of time. And I just wanted to say that all of those quotes were taken from a seeking safety little coping cards that we actually use with patients, which is why I've kind of embedded them throughout the talk. Things that can be inspirational, help people face traumas and find ways to recover. So thank you very much, and I look forward to hearing from the other co-presenters.
Thank you very much, Tim. I really believe that our technical difficulty that happened earlier happens because we want to bring a full circle to the panel. So right now, I would like to invite Connell to come back and do the last presentation, and then everybody will come up and answer questions.
Thanks very much. Hi again. So, as I had been saying before, I think the preamble to this afternoon's plenary correctly, in my view, focuses trauma work very much within the context of syndemic or overlapping psychosocial problems that impact populations at risk for HIV, or maybe impact different patients' abilities to be able to manage HIV for those who are already living with the disease. It was very interesting for me to sit back and listen to the presenters rather than have to present first. I think one of the commonalities across everybody's very different presentations was how important it is to specify context. And I think that's a big part of the work that we do in our research groups in terms of developing these integrated treatment platforms, where we're trying to examine some of the issues that are unique to the intersection of some of these risk factors. One of the largest studies in recent times on gay and bisexual men, Project Explore, was conducted in 5 studies across the US and recruited more than 5,000 gay and bisexual men with sexual risk for HIV. And that really showed us the extent, you can see on this slide, of the psychosocial and substance use issues that are prevalent in this group. And this is really the context in which we are working. I just wanted to mention some of the other ongoing clinical intervention programs that we're currently working on that favor this integrated treatment approach. Project Impact, which has just completed the second phase of an RCT looking at integrating treatment for crystal meth dependence and depression in gay and bisexual men at risk for HIV. Projects Target and Triad, which I'll be talking about tomorrow morning in a symposium with Jeff Parsons looking at depression and adherence in folks managing HIV. There's a significant overlap between smoking and anxiety disorders, and that's nowhere more obvious than in people who are also managing HIV. And then Trevor Hart's work, we're looking at the overlap between sexual risk and social anxiety, which some of us got a closer look at a few minutes ago. What I wanted to spend most of my 15 minutes talking with you about this afternoon is Project Thrive, and this is a programmatic area of work where we're interested in taking a look at and taking a chunk out of the deleterious effect of childhood sexual abuse that has on gay men's ability to keep themselves safe and healthy in sexual situations. And we've got 3 different studies, 2 that we've completed and 1 that's ongoing. And I'll move through these slides pretty quickly because I want to take as much time as I can to share with you the results of our current study. Before I do, though, I think it's important to ask the question, since we are interested in context, of why would you bother addressing childhood sexual abuse in gay and bisexual men if you're interested in protecting their adult sexual health? What's the connection? And it's a good question to ask because the answer isn't always that obvious. But one of the things that the last 2 speakers got to is that the rates of childhood sexual abuse among gay and bisexual men is really alarmingly high. In Project Explore, 47% of the sample were reporting childhood sexual abuse. In addition, childhood sexual abuse is repeatedly and across multiple epidemiological studies associated with increased rates of HIV infection. Some of the work that we did down in Boston, I should say, a few years ago was a secondary data analysis of the Explore data showing that gay men with histories of childhood sexual abuse failed to derive benefit from the Explore intervention. People who have childhood sexual abuse, you hit them with a HIV prevention intervention, doesn't do them any good. They can't use it for some reason. We'll talk about what some of those reasons might be. And then finally, the additional nail in the coffin is that childhood sexual abuse is itself associated with everything else that's associated with increased risk for HIV, depression, PTSD, and substance use, as Tim just reminded us. There was a study that came out 2 years ago that for the first time provided us population estimates of rates of childhood sexual abuse in sexual minorities with a heterosexual reference group. This is brand new. The other estimates that we just heard the previous speaker, Tim, talk about, those are estimates based on very small, convenient samples. And our concern was that those samples were wildly inaccurate because the sample size and sampling methodologies were so different and disparate across those studies. This is based on the NESARC data set and with a sample size in excess of 38,000, showing that the rates of childhood sexual abuse for women are about 3 times that of men. But when you start getting into the sexual minorities, you look at the odds ratios for gay and bisexual men, they're astronomically high. So that when we're looking at rates of 47% of gay and bisexual men reporting histories of childhood sexual abuse, those appear to be realistic and reliable population estimates. When we look at some of the data that's available here in Canada, the situation looks pretty bleak as well, with some suggestion here that Aboriginal men who have sex with men may be at particular risk for childhood sexual abuse. Several of the presenters have spoken about what's the connection between trauma and PTSD. Thankfully, the epidemiology on this is outstanding. It's not often that we can say that, but 30 years of epidemiological studies on childhood sexual abuse in gay and bisexual men have shown us the upstream effects. And I've broken them down here into these 3 different categories that will become apparent. Gay and bisexual men with histories of childhood sexual abuse are more likely to report the variety of substance uses, alcohol abuse, dissociation, depression, anxiety, self-loathing, self-hatred. Those of us who work in clinical practice are well used to seeing these issues present clinically. And then some of the more externalizing emotional distress, hostility, anger, sleep disturbances. The more downstream effects then, gay and bisexual men who report histories of childhood sexual abuse are more likely to report sex with multiple partners, more likely to report sex in the context of drug and alcohol use, more likely to report exchanging sex for drugs or money, and more likely to report unprotected anal sex. This then is why it's so important to treat childhood sexual abuse as one of the central pathways for HIV infection. And this then becomes our treatment model, because this tripart category of epidemiological results actually breaks down into the 3 symptom clusters of PTSD, avoidance, intrusions, and hyperarousal. And when we move from the epidemiology to specifying the treatment targets, which those of us who are clinical psychologists, clinical social workers, and mental health professionals need to do, this is what we come up with. And this was our treatment model when we selected one of the empirically supported treatments for treating PTSD is called cognitive processing therapy. It typically runs for 8 to 12 sessions. It's typically run as an individual-based therapy. We integrated it into 2 sessions of sexual risk reduction counseling and 8 sessions of cognitive processing therapy, where essentially there's nothing we can do about the fact that somebody was traumatized during the developmental phase, sexually traumatized. We can't change the fact that that happened, but we can help them look at their interpretation of what that means that that happened. And we can try and offset the damage that the experience of that trauma continues to have in adult sexual situations. And that's the goal of these sessions. We started off in the first study with just 4 people. Again, we're looking here, the purpose of this intervention is to jazz up people's cognitions, principally their thoughts about themselves and their ability to protect themselves in adult sexual situations. We selected into the study men who reported recent sex with men, who reported histories of childhood sexual abuse, and who reported multiple episodes of sexual risk for HIV, that is, unprotected anal intercourse, either insertive or receptive, in the past 3 months. One of the things we see here, I'm going to move quickly through this, but you can see these are the graphs of the 4 people who went through the intervention. And this is the depicting over the 10 sessions of the intervention, how they got on in terms of their trauma symptom severity. And you can see it's pretty variable. They're all over the place. And this is one of the things we wanted to see if we could do, if we could engage with people around their trauma symptoms, which it looks like we were able to do. One of the encouraging things here is each of the 4 participants ended treatment below their baseline. So there was, although variable, a decrease in trauma symptom severity over time. This is the impact then over 9 months of follow-up for each of these 4 participants on sexual risk. And you can see that all 4 participants were able to reduce their sexual risk. We conducted exit interviews on each of these 4 participants to get a sense from them, what was it like to go through these 10 sessions, to engage with a therapist around sexual risk in the context of having been traumatized sexually in childhood. And these were the 4 themes that emerged. People really appreciated the time and the opportunity to talk about sex. You wouldn't think you'd need to encourage gay men to do that, but they appreciated that. Everybody felt that the course of therapy was too short, that they still had issues to work on. And people appreciated the therapist. The second study that we did was we then took this intervention that we had specified with these 4 participants and we randomized 45 people to receive this 10-session intervention or just testing and counseling. We got some really nice effects on that On condom use self-efficacy, pre-post tests, those who received the treatment had better condom use self-efficacy, engaged in less avoidant coping. The big news here is that their trauma symptom severity decreased from diagnostic levels of PTSD to sub-threshold for diagnosis, where there was a non-significant increase, the green line, in the control group. And the big news is that we found close to a 50% reduction in rates of sexual risk among these risky gay men, that they were able to take, unlike the Explore intervention, they were able to take this 10-session intervention and use it to change their sexual behavior and change their interactions with their sexual partners. The third stage, which is a multi-site efficacy trial, and we're in year 3 of a 5-year trial at the moment, and we've recruited a little more than half of our sample so far. I wanted to take some time just to share with you some of the initial results of that. This is hot off the presses. I'm delighted to be able to share this with you. So who are these men that we're treating? We've randomized across 2 sites more than 100 people. The average age is guys who are close to being 40, who are lower SES by and large. We've got a good mix of people who are identifying as gay and bisexual and people who have other sexual orientation identities. But everyone here are men who have sex with men. Most of our sample are single. And we have good ethnic and racial diversity, helped by the fact that one of the study sites is in Miami. This is a particular important slide I wanted to share with you. For looking at the number of male sex partners our participants are reporting in the previous 3 months, this is an average of 7 male partners in the previous 3 months, with a standard deviation showing you the kind of range that we're working there, and that most of these partners are obviously made up of casual partners. 65% of the sample are reporting unprotected anal intercourse at baseline, and 35% reporting unprotected insertive or intercourse with primary partners. Most people reporting risk with casual partners. That's new. There have been some suggestion in the last 10 years or so that risk for gay and bisexual men was increasingly with primary partners. That doesn't seem to be what we're seeing in our study. This then is perhaps the most alarming of the clinical data that we're getting from these 100 or so men who we've enrolled in our study. We have a very brief childhood sexual abuse assessment that we do. We try to gather the information without activating anybody, without taking people too far back into the experience of the trauma, because we don't want to upset people needlessly. And this information is garnered by asking questions that are answered either yes or no. And we assess childhood sexual abuse in 2 age ranges, before the age of 13 and then between the ages of 13 and 16. To meet a criteria for abuse in the earlier age group, you need to be reporting sex with somebody who's 5 years older than you. And in the second age group, somebody who's 10 years older than you, or having sex where there was either force or the threat of force. And what we find, you see here, abuse that involved touching or being touched is coming in at 86% and 71% in the lower age group. But sexual abuse occurring before the age of 13, in nearly 50% of these guys, includes sexual intercourse. That number is less past the age of 13, but also you see the numbers there where people are, where there's the use of force, are also quite alarmingly high. I'm running out of time, so I was going to share with you some of the information on how we recruit our sample. Since gay and bisexual men with histories of childhood sexual abuse who are treatment seeking are kind of a hidden group of a hidden group, and it creates its own challenges for conducting this kind of scientific research. But I'm out of time. I just wanted to finish up on some key points that I think are underscored by this. this symposium that psychosocial problems are common among gay and bisexual men. They seem to accentuate the pathways to sexual risk. They don't occur in isolation. They overlap and they have an additive effect. We have a rich arsenal of empirically supported treatments to change behavior and address the mental health and substance use challenges that get in the way of changing behavior. And I think, as our previous presenter was suggesting, we really need to focus our intelligence and creativity on building these integrative treatment models that will allow us to take a much bigger chunk and help us to avert new cases of HIV among gay and bisexual men. None of this work is done by any individual. This is a huge collaborative effort down in Boston. Wanted to thank them too. Thank you very much.
So I would now invite Kenneth, Tim, and Peter to come back and to the front. We have 5 minutes for questions. And so if you have a question, please go to one of the mic. And since we only have 5, we do have someone. So yes, go ahead.
Hi, my name is Wayne. I'm a trauma survivor who had the condition develop into PTSD, and I'm really grateful and thankful to the OHTN for providing the opportunity to have this exposure provided on the condition today. I want to thank you. I'm a member of a community who seems to not really understand the issue, because HIV for me is a symptom of my trauma. It's a resultant effect. And I want to thank, I don't have the names right now, but the gentleman from CAMH, I want to thank you for referencing the spiritual, because it totally does destroy one's spirit. And in order to rebuild, I think we need to have a more normalized approach and response to the whole condition, because it's something that isn't really addressed and recognized to the fullness that it needs to be. And in the normalization piece of it, you referenced also, Colin, about the majority of treatments are too short. I couldn't agree more. It's a lifelong process. So that said, the work you're doing, how is it going to be better facilitated to transfer that out to the service providers, who for the most part I'm finding, as a survivor myself living with it currently, is they don't understand the need for access to education, to rehabilitation, to working this into the whole HIV piece. And I'm kind of lost there today as a PHA with this condition. So I'm just wondering what the challenges you're facing, or what you see coming to better educate the service providers that are out there, especially from the PHA, for the PHA perspective.
It's the key question. As those of us who are working within the research context, the community-based research context, to not just develop effective, efficacious programs, but also to have an eye to what's going to be sustainable, what's going to be used in the community health centres where they're needed. And I'm fortunate enough that where I do this work down in Boston, that is a key priority among our funding agencies. So we have built into the efficacy trial some major changes from the earlier 2 studies. We use community-level therapists. We have our study fully integrated into community settings in both of the sites where it's run. And we monitor, as part of ongoing supervision of the therapists who do this work, their ability to implement this treatment as it's designed. All these things are seen as strategies that will help move this intervention from a rarefied research environment into and sustained in the community setting. But it's not easy, and there are no guarantees with this. And it's a problem across psychological and other psychosocial interventions across the board. But I particularly appreciate your question. For those of us who are working in HIV prevention, there is still this idea that our HIV prevention interventions need to be brief and they need to be scalable. And this isn't one of those cases. And we need to, I think, shout particularly loudly when people are saying, oh, your intervention is too long. Standard treatments, as Tim showed, standard treatments for PTSD range from 12 to 24 sessions. And thinking that you can treat PTSD in something 2 30-minute sessions, I think is kind of a joke.
And to add to that, I think about my work clinically is in substance use in a downtown hospital where there's a lot of comorbidity with homelessness, high HIV risk, borderline personality disorder. I mean, just complex problems that people present with. And I was looking at slides and thinking 10 sessions, like, I don't see anybody for 10 sessions. Like, I know when I take someone on, this is going to be years commitment in some ways. And when I try thinking through how will we, it's a puzzle to me still. How will we make this so that we know that people will have access, or not on, because we'll have access to something in a community setting. And when we think about our mental health system in Ontario, probably most of Canada, is totally fragmented. So the idea that we will be able to successfully roll something out is a complex, I don't know which one I'm going to do. I'm talking on this one now. I feel like Oprah now. That we're going to be able to find something that is scalable, most of the research we're talking about is making use of very highly trained therapists. Even in the settings you're talking about, I can't think of very many community settings where we would be able to recruit the type of people we're talking are at the most high risk right now. So this is work we need to do. This discussion, your question, helps start that thinking. I think that is what's so critical.
And then, I don't know if I guess my microphone might be on. And then I think another perspective is to look at the fact that in research, because we're doing research, we often try to manualize things, have a time limit to them. But as you're raising the issue, the journey to recovery is really a journey, and it's often not easily manualized as researchers would like to see it, right? And each person throughout their life and the course of recovery can take variable lengths of time, and as also we've discussed, depending on the situation and context. You can feel better. I like that graph up and down, but this is what clinically people experience. There are times when you feel better, even at the end of 12 sessions, and then there are times when symptoms come back. So how do we have a life course trajectory approach and not a manualized approach? That's one thing. Second thing is, I think it's now increasing awareness, the importance of trauma-informed care. That is to say that not only do you get, intervention-specific trauma in those 12 sessions, but really the whole healthcare system need to be aware of the issues of trauma. So that every point of contact, there is a promotion of healing, and there is not an exacerbation of trauma. So this is a larger systemic perspective, right? Because I don't think there's enough resources to train enough psychologists in the world to administer all these therapies. So how do we maximize the whole care system so that in some ways there's a promotion of recovery? And thirdly, I was going to share this with you in the speech, and that's there was a documentary looking, for instance, in recovery of trauma in Cambodia, looking at how do people get over the trauma. And in the documentary, it looks at kind of three approaches. There is the conventional psychologists doing manualized treatment and evidence-based treatment. But also, there are people who feel that their recovery is aided by their religious practice, spiritual practice. You actually just mentioned that. So they interview people whom they thought that for themselves, the most important ingredient wasn't to go to psychologists, but was to have their faith reaffirmed, or to go to a Buddhist monastery, or to hear Buddhist teachings, for example. And then there's a third one, which is, in that particular case, the International Tribunal of having kind of legal justice. And then they also interview people who were active in trying to, in the community, to help out others. So we see that there are different avenues to promote recovery. And I think that that's kind of broadening approach, even though we like evidence-based psychological intervention because that's our area of interest. It also mechanistically makes sense. But we also need to look at a more holistic way of enhancing recovery, both at an individual level, but also in a community level, in a psychological way, but also through other avenues where people and communities can get healing.
So Peter, do you have
I
anything
was just going
to
to
add?
add to your point. It's a very critical point that many Aboriginal communities in Northern Ontario are facing. I mean, like in urban centers, there's much more opportunities to get training and to do a lot of research and test subjects out and methodologies. But when you go into northern communities where you have to fly in, it becomes very difficult to find staff that are trained in this particular area. And so that's one of the areas that we're really struggling with is like, how do you transfer knowledge into the communities and how do you ensure that the knowledge is in the best interest of the client? I think the second part that we have to realize from an Aboriginal perspective is that our workers in communities wear many different hats. So they can't be specialized in one particular area like HIV or AIDS. Many of them have to be specialized in child welfare, substance abuse, trauma, and they have to be the hat of the community. And so they're wearing many different intervention hats. And I think a third point that is that I want to raise is that many of these workers operate in isolation in communities. So the amount of intervention that they're required to do and the education that they're supposed to get, some of these workers get overwhelmed and they don't have a place where they themselves can get help. Most of them themselves have vicarious trauma through their work, and many of the workers themselves have been on a journey of healing themselves. So it's a very difficult question because it's easy to answer in some perspective, but when you're working with communities that are remote, and there's a lot of access issues and people that are qualified, it becomes a very complicated question. So I really can't answer that question from a First Nations perspective. I mean, I can write something down, but whether that gets delivered into communities, that's a different question.
So in light of time, I'm sorry that Dr. Hart, I cannot give you any time, because Curtis is there to take away my power. So I would like to close by just a very quick message that I got out of this panel. Thank you very much. I learned that trauma-informed practice is critical not only in research, but also in services and practice, as well as public policy, because we hear that trauma is actually something that is being transmitted from generation to generation, as well as being triggered. And there are many of us who continue to experience trauma in our everyday life until we live in an equitable world. So I would like to ask you to join me in giving a hand to our wonderful speakers. And I'm walking off the stage. Let's go. You guys, come on.